Good morning. This is Genevieve Crane. I'm broadcasting from my new home in Cleveland. I recently joined Cleveland Clinic. I'm going to be continuing with the last 8 cases of the hematopathology potpourri for board review alongside Dr. Logavi and Dr. Mirza. Our first case is a piece of squamous epithelium. So actually a piece of the oral mucosa. What we see here is the squamous epithelium itself appears relatively benign, but it's undermined by these atypical, somewhat discohesive cells, monotonous in appearance, and fairly aggressive in appearance. We can see most of them have fairly open chromatin and prominent nucleoli. Some forms are binucleate, such as one here on the lower right-hand side. And mitotic figures are relatively readily identified. Let me see if I can find one here for you. Yes, here's one coming into field. In addition, scattered apoptotic bodies. So overall, these cells have sort of a plasmablastic appearance, and we know it's in the oral cavity, and it appears to be aggressive given all of the evidence of mitotic figures that we have. And indeed, this was a patient with a history of untreated HIV and a lesion in the oral cavity. These sometimes can be challenging because they'll be negative for a lot of our classic stains to look for a hematopoietic malignancy such as CD45, CD3, and CD20, but they do express markers typical of plasma cells such as CD138, which also, of course, can be expressed by epithelium, but more specifically CD38, MUM1, part of P63VS38C, and markers of plasma cell differentiation such as BLIMP1 and XBP1. They also will typically express cytoplasmic light chain. A subset of them will be positive for CD79A, and CD10 can also be seen. CD30 is another potentially useful marker for these, and epithelial membrane antigen, or EMA, is frequently expressed. The majority of cases, particularly in the oral cavity and particularly in the setting of HIV, are positive for EBV by EBER in situ hybridization. Outside of the oral cavity, it may be a little bit less. And outside of the oral cavity, we might also see a greater degree of plasmacytic differentiation. And as I mentioned, they're typically negative or only weak staining for CD20, PAX5, or CD45. And sometimes a differential, particularly maybe outside of the oral cavity and with greater degrees of plasmacytic differentiation, you could wonder if this is a plasmablastic form of plasma cell myeloma. And indeed, that should be excluded, particularly in cases where you see CD56 expression. In plasmablastic lymphoma, MYC translocations are common. Around 50% of cases will have a MYC translocation, often in combination with with a translocation partner being an immunoglobulin gene. The prognosis remains poor for this lymphoma, with a median survival of only 6 to 11 months. And here's some images I took of, I believe it might have been the same case, and you can see the nuclear morphology a little bit better with the standard photomicroscopy here, with numerous mitotic figures and these prominent nucleoli with open chromatin. In some cases, you'll see staining with T-cell markers as well. There is some lineage ambiguity, particularly in the setting of immune suppression and with EBV positivity. In this case, it's only dim and would be unlikely to be confused with a T-cell lymphoma, but that is something to be on the lookout for. This is our second case. It looks like an enlarged lymph node. We take a look initially at the capsule of the node. It does not appear thickened, and the overall lymphoid architecture appears to be effaced. There's kind of a vague nodularity, but we're not seeing reactive follicles. Kind of zooming in as the image renders here, looks like a number of kind of small lymphoid cells and kind of this diffuse proliferation here of a mixed inflammatory infiltrate. There's some fine fibrosis that we're appreciating here, some potential increase in vascularity, but we're not seeing big bands of fibrosis. They're not as prominent as they could be in this entity, but scanning around, we do find some larger atypical cells, some which are mononuclear. This one highlighted here is multinucleate and has relatively prominent nucleoli. We'd like to get a little bit closer, but unfortunately the scan resolution doesn't allow us to do that. And here's a few more of them here. Again, attempting to get a little bit closer, but we can't quite. Some of these atypical cells with a little bit more abundant cytoplasm and multinucleate and with prominent nucleoli. And again, a few more here. The background infiltrate seems to be predominantly small lymphoid cells, occasional plasma cells we can see that have more eccentric nuclei and kind of a deep blue cytoplasm and that paranuclear HOF. There's also occasional eosinophils, although they're not prominent, and interspersed macrophages are here, although are not incredibly prominent either. And here's just a few still images I had taken to give you a better idea of the same case. Again, showing these larger atypical cells. Overall, this ended up being diagnosed as chronic Hodgkin lymphoma. That would be challenging to do on the H&E alone. It'd be very helpful to have a CD30, CD15, PAX5 to be certain that we did have these large CD30 positive cells with co-expression of CD15. This sort of mixed cellularity picture could bring to mind other possible EBV-driven processes. So you'd want to see that the Epstein-Barr virus was fairly localized to the large atypical cells rather than being admixed small to medium lymphoid cells as well. Now, this particular patient also did have HIV. These are seen in approximately these mixed cellularity forms are seen more often in patients with untreated HIV, with nodular sclerosis, Hodgkin lymphoma increasing in that population in the setting of heart therapy. Overall, historically, this subtype of Hodgkin lymphoma will comprise around 20 to 25% of Hodgkin lymphomas, often seen in peripheral nodes, as this one was here. Involvement of the spleen in 30% of cases. Bone marrow involvement is not uncommon, in contrast to nodular sclerosis, Hodgkin lymphoma, and mediastinal involvement is actually uncommon in this subtype. The majority of cases are EBV associated. EBV is more common in HIV infection, and the majority of patients, around 70%, are men. This can also be seen in the pediatric age group, particularly in the developing world. There's also a second peak without geographic restriction that's seen in elderly patients. And this is a separate case where a lymph node specimen was taken and found to be consistent with mixed cellularity Hodgkin lymphoma, and it also involved the bone marrow. In the bone marrow, it's a little bit more difficult to do the subtyping, but it's more commonly seen in the setting of a mixed cellularity Hodgkin lymphoma. And as we can see here, the bone marrow, this is around a 45-year-old patient, is very hypercellular, and we see these nodules with an atypical inflammatory infiltrate and some scattered large atypical cells in the background of fibrosis, histiocytes, and small lymphocytes. The large atypical cells are positive for CD30, CD15. This can be somewhat confusing in the bone marrow, as myeloid elements can also express CD15, but here we see that these large atypical cells are indeed expressing CD15 and CD30. In this case, they had very dim PAX5. I apologize for kind of the little noises in the background. My cat is walking around everywhere behind the scenes. Okay. The large atypical cells are positive for EBER, here done by in situ hybridization. And on deeper levels, we actually uncovered a larger number of these Hodgkin-Reed-Sternberg-like cells with also some background, probable background reactivation as well. But they were also positive for the EBV latent membrane protein 1, which is typically seen in classic Hodgkin lymphoma when it's EBV associated. This is our next case. This is more of a classic Hodgkin lymphoma case. And here we see that we have a very thickened fibrous capsule, as well as these fibrous bands throughout the infiltrate. And there's a nodular inflammatory process. And anytime you see this, particularly if you know it's a young patient with a mediastinal mass, your radar is going to go up for concern for possible Hodgkin lymphoma, in particular the nodular sclerosis subtype. And looking more closely, indeed, we do have, again, a mixed inflammatory infiltrate. Here we see some larger atypical cells that have more complex nuclear features, are multinucleate and have prominent nucleoli, fairly abundant pink cytoplasm. The background here, as compared to the prior, contains a few more histiocytes as well as eosinophils. Plasma cells are again appreciated, as well as small lymphocytes. And just cruising around here, again, we are seeing a little bit more prominence of the eosinophils. A few areas that I marked, waiting for the image to render a little bit, but here are again some larger atypical cells, which are multinucleate. Also here, along with an area of necrosis and numerous apoptotic cells, which can be seen. And again here, more areas of focal necrosis within this process. Again, in a background of some of these large atypical cells. Some of them you can see have their cytoplasm being slightly retracted, and we call those lacunar cells, which is characteristic of the nodular sclerosis subtype. I'm just loading the next, sorry, I have to upgrade my internet here. Loading the next image. Yeah. So these are just some still images that I took here, showing a little bit better image of the large atypical cells with these complex nuclear features and fairly intense multinucleation in this case. And so this was ultimately classified as classic Hodgkin lymphoma, nodular sclerosis subtype. This comprises around 70%, the subtype comprises around 70% of the Hodgkin lymphoma cases seen in the United States and Europe. Mediastinal involvement is typical and seen in around 80% of cases. As we saw here, they typically have a nodular growth pattern with nodules surrounded by collagen bands, and you need to find at least one such nodule to make that diagnosis. Hodgkin-Reed-Sternberg cells may show retraction artifact, as we saw, the so-called lacunar cells, and in some cases you may see a larger number or prominent aggregates of Hodgkin-Reed-Sternberg cells, and this is the so-called syncytial variant, and that can be seen with some frequency in the setting of the nodular sclerosis subtype. Now here's our next example. This is a piece of tissue which has been largely had its architecture effaced by some sort of atypical infiltrate. But we do see here that we have some, some fragments of bone here, as well in the lower portion of the field, suggesting that this may have come from a bony site. The atypical cells themselves are quite pleomorphic. Some of them are larger with sort of blastic chromatin. Other ones have a slightly more condensed chromatin. They have relatively moderate amounts of cytoplasm. Some of them have kind of indented nuclei or maybe even horseshoe-shaped nuclei. I apologize for that. The mouse is a little bit jumpy. And we do have some areas, let me see if I can get to them, with numerous interspersed giant cells. And all of these features are fairly characteristic, although you can see kind of a broad morphologic range in adult T-cell leukemia lymphoma, which is associated with HTLV-1. Now, this diagnosis is one that you definitely would want to make in the appropriate clinical context, in particular in patients who may have had exposure, such as in the Caribbean Basin, to HTLV-1. This patient, as we'll see on the next slides, was a little bit atypical. He was very young, 17-year-old boy. Now, he did have a connection to Jamaica. His mother was Jamaican. He was born in the United States, but had multiple visits there as a child. And he presented with a hypercalcemic crisis and acute renal injury, and also did have these long-standing atypical lesions on his skin, which had previously been evaluated and found to contain some atypical lymphoid cells. On scan, he was found to have multiple lytic skull lesions. It is one of these lesions that was assayed that we showed in the initial whole slide image. This disease is caused by a retrovirus, human T-cell lymphotrophic virus type 1. It can have a variety of clinical presentations that have very kind of different clinical courses, divided into smoldering, chronic, acute, and lymphomatous presentations. The skin lesions are seen in more than half of the patients, and hypercalcemia is another characteristic finding. Typically, the peripheral blood will contain these characteristic multi-lobed neoplastic cells, which have been termed flower cells. They're not present in every case, although they're very frequently present on a case presented within the boards. Unfortunately, this disease is associated with a very poor prognosis, particularly when presenting in advanced or clinically aggressive disease. And these cells are actually derived from T regulatory T cells, which we'll discuss on the next slide, but that alters patient immune function in addition to the extensive involvement by the lymphoma, and death is often secondary to infectious complications. So this morphology, this is just so still images of the same case. Again, it's very difficult to diagnose on morphology alone. They may have a broad morphologic spectrum and mimic other lymphoma subtypes, such as angioimmunoblastic T-cell lymphoma or Hodgkin lymphoma. And there was a very nice paper on this from Dr. Chapman's group, looking at kind of a range and potential pitfalls with these types of lymphomas. And one thing to note, as we did see in these cases, in this particular case, is that they may show significant pleomorphism, including some of these multinucleated giant cells, which we saw in this case. So it is a T-cell lymphoma. It typically does stain positive for T-cell markers such as CD2 and CD5. They typically lack CD7. Surface CD3 may be dim or negative, but cytoplasmic expression is typically seen by immunohistochemistry. The majority of cases are CD4 positive. Rare CD8 cases are described, as well as CD4, CD8 double positive cases. This patient actually did have a subset of CD4, CD8 double positive cells. CD25 is a good characteristic marker, although it's also an activation marker that can be expressed in a variety of T-cell lymphomas. CD30 is typically expressed in the large cells. It is thought to be, as I said, derived from regulatory T cells. These typically express FOXP3, although FOXP3 expression is somewhat variable, typically in the tumor cells. In contrast to EBV, we are not able to directly test the tumor yet for HTLV-1, but usually this is confirmed by serology or PCR-based studies, and a high level of suspicion is warranted in patients who may be at risk, such as patients who have had exposure in the Caribbean Basin. Now, of note, a large population may be infected with HTLV-1. It usually remains latent. Complications, which vary, may be seen in up to 4% of individuals. So the lymphoma is still relatively rare, even within potentially affected populations. And it is extremely rare in pediatric populations. It's usually associated with a long latency. This particular patient had a premature birth and was given breast milk at the time to help him recover, and it's thought that potentially some infection occurred during that neonatal period, which led to his earlier presentation, but that we don't really know. Okay, moving on to our next case, and this is actually, as you will see, a piece of lung. The lung parenchyma looks fairly benign, but we do have an area of, I'll scan out of it, of this kind of large mass lesion, which was noted on scan as an elderly gentleman with a solitary lung nodule, and they definitely wanted to evaluate that to see what it might be. You can see here, it looks fairly poorly cellular. We see some scattered, what appear to be prominently plasma cells. Sorry, it's a little bit jumpy, as well as some associated lymphoid cells and a very large number of histiocytes and cells we can't necessarily tell what they are, but they seem to contain this sort of grungy, but actually rather crystalline material. We see some of these crystalline shapes in here, which are likely inside of macrophages. Some of them are also inside of the plasma cells as well. We can see that many of the plasma cells do have prominent Russell bodies in various places. Many of the plasma cells are mature in appearance, but we do have some that are slightly more atypical with open chromatin and prominent nucleoli or much larger size. But overall, it's very paucicellular infiltrate, and it's hard to necessarily appreciate lymphoma as much in the background of this process, with predominantly just these atypical plasma cells and numerous histiocytes. And indeed, this is an example of crystal storing histiocytosis. As I mentioned, it was an elderly man with a solitary lung nodule. You can envision that serum studies would identify a monoclonal protein subsequently. This is a relatively rare entity, and it's characterized by histiocytes with abnormal intralysosomal accumulation of immunoglobulin as crystals. Patients typically do have an underlying plasmacytic or lymphoplasmacytic neoplasm, but that process may be somewhat obscured by the extensive crystal-storing histiocytes, as was seen in this case. And it may be either localized or systemic. But it's important to exclude other potential conditions that could mimic crystal-storing histiocytosis, such as infectious complications that may have histiocytes with abnormal material in them, such as mycobacterial fungal infections, malakoplakia, or even hematophagocytic lymphohistiocytic histiocytosis. Storage diseases, again, within the appropriate clinical context, could be considered, such as Gaucher's, or histiocytic lesions, such as xanthogranulomas. Other tumors, such as granular cell tumor, could potentially mimic crystal-storing histiocytosis in some cases. So definitely a diagnosis to make with some caution given its rarity, but it does have some very characteristic features. The mechanism behind it is kind of interesting. Initially, the cases described were all kappa, and it was thought that, or were predominantly kappa restricted, and it was thought that particular mutations would be associated with increased crystal formation by kappa. A subsequent study found that variable region fragments of heavy chains were identified without a constant domain in a lambda-restricted plasma cell population, suggesting that the variable region may also be prone to mutations leading to crystal formation. And there's an interesting paper from the MD Anderson group, Dr. Kanagal-Shamana, published a few years back on this topic. Also, I'm still a fan of some of our classic histologic staining methods. This is one you can use to really highlight these immunoglobulin crystals within crystal storing histiocytosis. which works in some cases. This is the phosphotungstic acid hematoxylin stain or PTH stain, highlighting the crystals here, as well as some of the Russell bodies.